So, good evening, students. Good evening, everybody. Today we will be discussing about endovascular therapy in large infarcts. We have two articles from NEJM, and both articles will be discussed, followed by a few comments. If possible, Dr. Dulari will give the comments. Otherwise, I'll close the discussion by offering the editorial comments. So I think we'll start the proceedings with Dr. Srihari, you can start your presentation.
Yes, sir. Good evening. Am I audible?
Yeah.
Yes. So, to begin, endovascular therapy in stroke, it has shown to be more effective in reducing disability than medical therapy alone in selected patients with ischemic stroke due to large cerebral vessel occlusion. So there were two trials, that was the DAWN trial and the DIFFUSE-3 trial for the extended thrombectomy efficacy and safety up to 24 hours from the last known well in selected patients. EVT is indicated for patients with acute ischemic stroke due to a large artery occlusion in the anterior circulation who can be treated within 24 hours of the time last known to be well. So eligible patients should receive standard treatment with IV thrombolysis if they present to hospitals where thrombectomy is not an option, and those with qualifying anterior circulation strokes from large artery occlusion should then be transferred to a tertiary stroke center in which intraarterial thrombectomy is available, a strategy called drip and ship. So there has been no evidence regarding endovascular treatment for outcome in strokes with large infarct core and low aspect score. Here we can see two images. Image A is showing the aspiration catheter engulfing the proximal end of the thrombus, and B is showing the stent retriever engulfing the thrombus. The stent retriever shape is changed at the location of the plug. These are just images of the procedure. Also, some techniques of endovascular thrombectomy, like the stent retriever, that is a third generation technique, and adapt. Also, other techniques like the Columbra, adapt, and penumbra. Most important for us is the MCA Alberta stroke program, early CT score, aspect score, that is used in detecting whether there is a large vessel occlusion or whether there's a stroke at using the NCCT brain. So here we have 10 points. It's a 10-point score system for rapid assessment of the MCA territory ischemic stroke. So M1 to 3 are at the level of the basal ganglia, M4 to 6 at the level of the ventricle superiorly. An aspect score less than or equal to 7 predicts poor functional outcome and increased risk of hemorrhagic transformation. So here you can see the image showing the M1, M2, M3 at the level of the basal ganglia, and M4, M5, M6, the level of the ventricle superiorly. Also, there is a posterior circulation aspects. It is also a 10-point score, but any pontine or midbrain involvement reduces the score by 2 points, regardless of either unilateral or bilateral presentation. So here we can see the 3 levels, that is at the thalamus, midbrain, and the pons level. So if the thalamus and the occipital lobe is involved, that is a point each, and midbrain level, and at the pons level, showing the pons and cerebellar hemisphere involvement. So coming to our trial, the first trial is going to be the Angel Aspect Investigators trial that has been published in NEJM on February 10th of 2023. So it is an original article. The name is The Trial of Endovascular Therapy for Acute Ischemic Stroke with Large Infarct. Coming to the trial design, it was a multicentric trial, randomized with an open label clinical trial and blinded endpoint assessment at 46 hospitals with comprehensive stroke centers conducted in China. The trial protocol was approved by the institutional review boards at Beijing Tiandan Hospital. The eligible patients were those who were from 18 to 80 years of age, those having acute ischemic stroke within previous 24 hours with an NIHS of 6 to 30, a pre-stroke MRS of 0 or 1, and large vessel occlusion of the initial segment of the MCA or the intracranial segment of the distal ICA or both. The imaging inclusion criteria was patients with an aspect score of 3 to 5 as per the NCCT, or patients with an aspect score of 0 to 2 from the NCCT within 24 hours after stroke onset, and an infarct core volume between 70 and 100 ml. Patients, those who are ineligible, were ones with significant midline shift, clinical herniation, mass effect, high risk of hemorrhage, and patients with acute bilateral strokes. Coming to the randomization and the intervention. So the randomization code from the central online network randomization system was retrieved. It was a 1:1 ratio randomly assigned for EVT and medical therapy or medical management only. The EVT group consisted of thrombectomy with a stent retriever or contact aspiration system, and if required, a balloon angioplasty, stent implantation, or intra-arterial thrombolysis. And the medical management group, it was as per the Chinese Stroke Association guidelines. So they followed IV thrombolysis using alteplase 0.9 milligrams per kg of body weight or urokinase 1 to 1.5 million international units. So this flowchart shows how the patients were randomized. So there were 1,504 patients who were assessed for eligibility, out of which 456 underwent randomization. At this level, they were divided into 231 that were assigned to the endovascular therapy group and 225 that were assigned to the medical management group. So in the end, the final number was 219 patients in the EVT group and 222 for the medical management group. The outcomes that were assessed were the primary outcome being the score on the modified Rankin scale at 90 days. The secondary outcomes being the scores of 0 to 2 MRS and 0 to 3 MRS at 90 days, NIHS score of 0 to 1, any improvement in the NIHS score of at least 10 points at 36 hours after randomization, and change in the infarct core volume from baseline imaging to NCCT at discharge or 7th day or an MRI at 36 hours. And the safety outcomes were symptomatic intracerebral hemorrhage within symptomatic ICH within 48 hours after randomization, increase in NIHS more than 4 or NIHS is less more than 2 with any ICH on imaging, or any ICH within 48 hours, death within 90 days after stroke onset, and the need for decompressive craniectomy. Imaging in this trial was performed at baseline, 36 hours with a window of 12 hours plus minus, and 7 days after randomization and also on discharge. So in the EVT group, the reperfusion was assessed with the extended thrombolysis in the cerebral infarction scale, the ETK scale. It's a 7-point scale with higher score showing greater reperfusion. And successful reperfusion was noted as ETK score of 2B50 or greater, that is equivalent to a 50 to 66% reperfusion. So the analysis done in this study was there were 2 interim analyses that were planned. One was when 1/3 of the patients had completed 3-month follow-up and 2/3 of the enrolled patients had completed 3-month follow-up. In the interim analysis, the trial would be stopped early either for efficacy if a pre-specified threshold, that was p-value less than 0.0123, was met for EVT based on shift in the distribution of the scores on the MRS, or for futility if results were inconclusive with current sample size. So coming to the results, the trial was started on October 2nd, 2020, and it lasted up to May 18, 2022. There were a total of 1,504 patients that were screened at 46 centers in China. 456 enrolled in the trial, of which 231 were to the EVT group and 225 to the medical group. All the patients completed 90-day follow-up, out of which 95 patients died before 90-day follow-up. The median interval between stroke onset and randomization was 456 minutes. The median baseline NIHS was 16. The median aspects was 3, and the median infarct core volume was 62 ml. This graph, it shows us the shift in the distribution of scores on the MRS at 90 days. So here we can see on top it is the endovascular therapy and the MRS scores, and the one below is the medical management group and the MRS scores. Here we can see there's a clear shift that is towards the outcome showing better outcome in the endovascular group over the medical group. This is in the MRS. Coming to the efficacy and safety outcomes. So the point to be noted here was the safety outcomes in the endovascular therapy group. We can see that there was significant symptomatic ICH within 48 hours in the endovascular therapy group. Also, the numbers that were showing any intracranial hemorrhage within 48 hours, it was 113 in the EVT group and 39 in the medical management group. Also, death within 90 days was 50 in the EVT group and 45 in the medical management group. Also, the patients who underwent EVT, they required decompressive hemicraniectomy during hospitalization. The number was more, that was 17, and in comparison to the medical management group, that was 8. So coming to the critical appraisal, was there a clearly focused clinical question and primary hypothesis? Yes. So the primary hypothesis was to test the hypothesis that EVT would be superior to medical management with respect to functional recovery among patients in a population different from that in previous trials. That is with a large infarct core caused by acute large vessel occlusion in the anterior circulation. Was the randomization process clearly described? Yes. They have mentioned that they were randomly assigned 1:1 ratio to EVT and medical management. And the investigator at each trial site obtained randomization code from the central online network randomization system. It was a simple randomization method and there was no stratification. Was concealed allocation used in the allocation of interventions? It was not used. Were the groups similar at the start of the study? The groups were more or less similar. So in the endovascular therapy group, we can see that the median age was 68 and medical management group, it was 67. The males were 135 and 144. We can see that the occlusion site number, that is M1 segment, was most common. That was 145 in the EVT group and 142 in the medical management group. So more or less all the initial at the start of the study, the groups were similar. And also the median infarct core volume, we can see that it was 60.5 in the EVT group and 63 in the medical management group. The groups were treated equally apart from the experimental intervention. Was blinding used effectively? Only the endpoint assessment was blinded. There was no other method to blind such interventions. Was the trial of sufficient duration? The trial, it lasted for about 2 years. So there were significant case numbers that were enrolled and study was completed in 2 years by the end of the interim analysis. And also by this time, the primary objective was met and it can be concluded that the trial was of sufficient duration. Follow-up was complete. All the patients completed 90-day follow-up. It was an intention to treat study. So coming to the assessment, so here we can see in the EVT group, the positive outcome was 153 numbers and the negative was 77, the total being 230. And in the medical group, it was 135 in the positive group and negative being 90, and a total of 225 patients. So on calculating the odds ratio, it comes to 1.32. The control event rate was 0.6. The experimental event rate was also 0.66. And absolute risk reduction was minus 0.6. So the relative risk that I could calculate was 1.1. And the numbers needed to treat came up to 1.6. Are our patients similar to the target population? There's near similarity in the stroke protocol and the burden of stroke, apart from the racial differences. Were all the relevant outcome factors considered? I felt that certain disease-modifying complications like hospital-acquired infections, they were not mentioned in the study, especially in the safety outcome. The intervention could help our patients. Are the benefits of the intervention worth the risk and costs? Yes, but there's a high risk of bleeding complications in these patients and ICH, and also there's an increased financial burden as the probability of need for decompressive hemicranectomy post EVT was more, and also the mortality rate within 90 days was more in the EVT group. Have patients' values and preferences been considered? Yes. What are the alternative treatments that are available? So that is antiplatelets, at times anticoagulation, heparin infusion for a thrombus, and statins. So to conclude, in this study, patients with acute stroke with a large cerebral infarction caused by a large vessel occlusion in anterior circulation had better functional recovery at 90 days with EVT administered within 24 hours than with the usual medical management. The conclusions resonate with the results. The investigators have mentioned their limitations in the discussion, and they've also told about avenues for future research. There's no bias, no recall bias, and the study has not listed confounders.
Okay, Srihari, I think you have presented very well. When both the control group and the experimental group has same amount of deaths, almost equal. So death as an outcome is not a very important issue here. Can you go back to the shift analysis graph again?
Yes.
Shift analysis, yeah, this one. Just make it a slideshow. Now you can see the difference in the outcome, which is a functional outcome with the endovascular therapy in each group. It is showing. I mean, if you go to the say, this is the 1 to 4, 1 to 4, and if you complete, how many numbers have got good outcome in this? Total numbers you have from 0 to 4.
About 153.
And for the other people, you have?
For the medical group, it was 135.
So I think there is our dilemma is always whether we should undertake endovascular therapy or not. Even if you take endovascular therapy into consideration, do you think there is a benefit?
Yes, sir. Definitely, functional outcome is better.
And that is at the 90 days.
Yes, sir. At 90 days.
MRS at the 90 days. And mortality is equal between both the groups.
Yes, sir.
Dr. Vivek, do you have any comments to offer?
Yes, sir. Actually, based on this study, hello?
Yes.
So they have included aspects of a very low score. Probably, I think 1 or 2 also they have included.
0 to 1.
So probably we have some scope. We can just refine the study. We can just include 3 to 5 group, which is more vulnerable, I feel. And probably we'll try to explore that option in the aspect CT 3 to 5. If we do thrombectomy, we can offer to them, and let's see the outcome, what outcome comes. And probably the outcomes will be much more refined than this, because 0 to 1 means very big infarct core.
Very big infarct.
And then definitely, I think they have not given any subgroup analysis of it. How much of it has 0 to 2 and how was their outcome? If the subgroup analysis they would have done, it will be a better picture.
And moreover, the time also, it's up to 24 hours.
Yes, the median time was there, sir, 480, which is, I think, sir, not that bad.
Srihari, can you tell the median time of intervention?
Some 480 minutes, I think, sir.
Yes, sir.
480.
So 8 hours.
8 hours, yes, sir.
So 7.3 is the best outcome margin. Yeah. So I think this is okay, but the median time have, but we don't know what is the range.
So in EVT it was 453 minutes.
Yeah.
And medical management was 463 minutes.
Yeah, so somewhere around 8 hours.
This is a median, no? So you should give the range.
So less than 4.5 hours, it was 46 in EVT and 51 in medical management. 4.5 to 6 hours, it was 36 in EVT and 34 in medical management.
Okay.
6 to 12 hours was 92 and 76.
Okay.
And 12 to 24 hours was 56 and 64.
That's again a major margin.
Major margin. Yes, sir.
Next.
And sir, he has rightly pointed out. So this was done in China. I think most of the patients are covered by insurance. So the financial burden will not be much. But in our setup, the financial burden is the main concern.
Yes.
So if patient we done successful revascularization, he lands in some ICH, required
Yeah.
decompression, then availability of neurosurgeon, their proactiveness of themselves,
Yes.
and finances. All these issues need to be taken into consideration.
Actually, one point I want to ask: how many cases are there up to 24 hours?
I think all are within
All
24 hours.
cases are up
No,
to
no.
24
What
hours.
is the margin which is beyond 16 to 24 range?
So they have given a range of 12 to 24.
That is how many?
That is 56 in the EVT group.
So if we bring down that time margin, we may have better outcomes.
Yes, sir. Yes, sir.
I think we should hereafter attempt to do as early as possible.
As early as possible, and probably we'll explore, sir, little lower aspects, probably 4 or 5 aspects we can explore.
Yes.
And then step by step, we'll go ahead little lower aspects. So right
Right.
now we are including all 6 and above. So 4 or 5 we
So,
can just take as a borderline cases.
yeah, we can bring it down. And
Yeah.
it's interesting to note about the posterior aspects. And shall
all
we
are,
include?
all are in the ICA, no, sir?
So this
ICA
study is
MCA
only
only.
for anterior
ICA and MCA.
circulation.
No, posterior circulation aspects also you mentioned. Are they included in this? They are not included.
No, sir. This is only AIS, sir.
So
It's anterior circulation.
we'll include in our cases posterior aspects also.
Sir, but what I have open in posterior circulation, sir, the aspect score is a little misleading because even our patient has infarct in only in the pons involved in the full cross section. His aspects will read 8, but still he may not have the good outcome because bilateral ponta involvement locked in status. So this is little fallacy of posterior circulation aspects, I feel.
Okay. But keeping today's case in mind, we are more confident in approach.
Yeah, sir. We can just give more little aggressive approach for posterior circulation.
And we should keep trying to open the vessel even up to 24 hours.
Yeah, that's sir. We are following that one, sir. We are following that one.
Gorti sir, can I just say one thing since the slide is up? Many times when they are doing analysis of stroke and talking about MRS and shift after a therapy, sometimes there's a fallacy that instead of aspect 6, which is death, our treatment is shifting all the patients who haven't died, but they've become severely disabled with an aspects of 5. So in this and in the other study also, the if you combine both aspects 5 and 6, which is
you are saying MRS 5 and 6.
MRS 5 and 6. In this both the studies, this one and the next study also, the total number of patients in MRS 5 and 6 is reduced in the endovascular group compared to the medical management. So deaths are kind of similar, but those who are in severe disability, which is MRS 5, has been significantly reduced. Some previous interventions, instead of the patient dying, the intervention just made them severely disabled, which might with probably very poor quality of life. So this is important that they are not dying and their disability, the severe disability numbers have also reduced. So this is a truly beneficial intervention.
I think you made it. That's encouraging, Dr. Vivek. We should go and do these cases, which we were not doing earlier.
Yeah, we are not doing earlier because we don't have data to support it. So tomorrow, if someone questions in clinical governance, we should have some data. This is a data sets. So that's why we have opted this treatment.
Dr. Dulari made a good point, and now I think we'll go on to the next paper by Gargi.
Yes.
Gargi, you can share your screen, and I think.
Yes, we'll start.
Yeah. You're able to?
Yes, sir. Just a second.
Yeah.
Sir, is it visible?
Yeah, it's visible. Put it on the slideshow.
Okay. Good evening. I'll be talking about the SELECT-2 trial, which is a trial of endovascular therapy for acute ischemic stroke with large infarction. It was published in NEJM on 10th of February 2023.
Gargi, can you make it slideshow?
Sir, it's on slideshow on mine.
Oh, it's not on sign. Okay. All right. Okay.
So just a second, I'll do it again.
Okay. Otherwise, continue.
Yeah. So now is it?
No, it's still the same. Doesn't matter. Continue.
Okay. So endovascular therapy has become a standard of approach in strokes with large vessel occlusion. The role of endovascular therapy for acute stroke with large infarction has not been exclusively studied in differing populations. Some local studies are there, but we don't have a data which supports, which can be generalized to all the populations. And endovascular techniques include thrombectomy with a stent retriever or contact aspiration. Talking about the aspect score, it is the Alberta Stroke Protocol early computed tomography score, where value of more than 6 is considered.
Gargi, your slides are not moving. Is it same for others?
Slides are not moving, sir.
This will stop other screen sharing. Do
Yeah.
you want to? Yeah, now they are moving.
Now it is appearing on next slide.
Yeah.
Yes, sir. So value more than 6 is the imaging selection criteria for endovascular therapy. It gives a measure of infarct size on scale of 1 to 10, where lower values indicate larger infarction. Similar such study of rescue called Rescue Japan Limit Trial has shown that patients with aspects value of 3 to 5 had better functional outcome with endovascular therapy than with medical care, but they had more intracranial hemorrhages. Methods and materials. It was a multi-center phase 3 international randomized open label clinical trial with adaptive enrichment design and blinded endpoint assessment was conducted.
Slide is not moving. No, now it has come.
Okay.
I think you must be doing some, adjustment you have to do, I think. Somewhere we have gone wrong in this.
Sir, I think when I put it on slideshow, it's stopping.
So you don't put it on slideshow then.
Okay. Try without that. The trial was conducted at 31 sites across US, Canada, Europe, Australia, and New Zealand. Primary objective was to determine whether a shift in distribution on scores of MRS at 90 days had occurred between two groups. It was funded by Stryker Neurovascular, grant from Stryker University Hospital Cleveland, Neurovascular to the University Hospitals in Cleveland Medical Center and University of Texas Medical School. The Stryker Neurovascular had no role in design or execution of trial or analysis of data. Patients eligible for the trial were those of age 18 to 80 years who had acute ischemic stroke within past 24 hours with NIHs of 6 to 30 and pre-stroke MRS of 0 or 1. Large vessel occlusion of initial segment of MCA or intracranial segment of distal ICA or both was documented on angiography. The radiological inclusion criteria included NCCT within 24 hours of presentation with aspect value of 3 to 5, with no limitation with respect to infarct core volume, or aspect of 0 to 2 with infarct core volume between 70 to 100 ml, or aspects value more than 5 and infarct core volume 70 to 100 ml. Exclusion criteria included patients with clinical signs of herniation, mass effect, midline shift, high risk of hemorrhage, acute bilateral strokes, and multiple intracranial occlusions. The interventions were IV thrombolytic drugs like altiplase or tenecteplase were administered to eligible patients who were first assessed within 4 to 5 hours after onset of stroke. Endovascular thrombectomy was performed with stent retrievers, aspiration devices, or both, depending on trial site. And decision to proceed with decompressive hemicraniectomy in patients with severe brain swelling were made in accordance with local practices, which could include IV thrombolytic and oral antiplatelet agents. So the outcomes under study were: primary outcome was the score on MRS at 90 days. Secondary outcomes included score of 0 to 2 and 0 to 3 on MRS at 90 days, NIHS score of 0 to 1 or improvement in NIHS more than 10 points at 36 hours, and change in infarct core volume at 7 days or at discharge, and target artery recanalization documented on CT or MR angio. The safety outcomes included symptomatic intracranial hemorrhage within 48 hours after randomization, defined as increase in NIHS of 4 points or more, any ICH within 48 hours, death within 90 days after stroke onset, and need for decompression craniectomy during hospitalization. The trial was conducted as follows. Clinical assessments were performed at baseline and 24 hours, 5 to 7 days, or at discharge, 30 days and 90 days. The score of MRS was assessed at in-person visits or by means of telephonic interviews with the patient. All patients underwent NCCT, CT or MR angiography and perfusion scan. Data for efficacy and safety outcomes was assessed after 300 patients enrolled in the trial had completed the 90-day follow-up. The statistical analysis trial was designed to have maximum sample of 560 patients with 90% power and alpha level of 5% to detect mean standard difference of 0.34. The probability of superiority value greater than 0. And generalized odds ratio greater than 1 indicated improvement of outcome in the thrombectomy group. Here we can see the gradation of the MRS scale with upper bar showing endovascular thrombectomy group and lower bar showing medical care group. Here we can see that there is a widening of it is in favor of endovascular thrombectomy group for every MRS score at 90 days. The results were 958 patients had been screened in total, out of which 352 were eligible for the trial, gave consent and were enrolled. A total of 178 were assigned to the thrombectomy group and 174 were assigned to the medical care group. Out of these, 3 patients were lost to follow-up before 90 days and 1 patient withdrew consent. Here we can see the 2x2 table in which odds ratio is of 1.5 in favor of endovascular therapy group. Primary outcomes at 90 days, the MRS was 4, median MRS was 4 in the thrombectomy group and 5 in medical care group. And the probability of superiority was 0.6 with 95% confidence interval. The generalized odds ratio favoring endovascular thrombectomy was 1.5 with 95% confidence interval and p-value less than 0.001. In this, we can see that the MRS in thrombectomy group is 4, median MRS, and medical care group is 5. The functional independence at 90 days in EVT group is 36, was in 36 patients, while medical care group it's 12, which is a significant difference. And independent ambulation at 90 days is 67 in EVT group and 32 in medical care group. Early neurological improvement was noted in 20 patients in EVT group, while only 13 patients in medical care group. The safety outcomes, there was increased number of symptomatic intracranial hemorrhage within 24 hours in 2 patients in medical care group and 1 in EVT group with relative risk of 0.49. But early neurological worsening occurred in 44 patients in EVT group and 27 patients in medical care group. Death from any cause within 90 days was almost equal with relative risk of 0.91. Arterial access site complications and vascular injury was more in EVT group, which did not occur in medical care. So the results of SELECT-2 trial showed that EVT plus medical care resulted in better clinical outcomes than medical care alone in patients with large ischemic core. Total of 85% of enrolled patients had aspects value of 5 or less, whereas 87% had ischemic core volume of 50 ml or more. 78% patients had large stroke according to both NCCT and ischemic core volume. Talking about similar trials, a Japanese trial showed the efficacy of thrombectomy in patients with aspects value of 3 to 5 on MRI when performed within first 6 hours after onset. Similar trial conducted in China, which we just saw, had similar results to this trial. And thrombectomy was associated with procedural vascular complications in all the above trials. Here, this is a forest plot showing that patients assigned to EVT group had a better functional outcome at 90 days as compared to medical care alone. But the widths of the confidence intervals were not adjusted for multiple comparisons in this trial, and hence these cannot be directly extrapolated for hypothesis testing. Coming to the critical appraisal of SELECT-2 trial, was there clearly focused clinical question and primary hypothesis? Yes. Primary hypothesis was to assess the safety and efficacy of endovascular therapy in patients with large ischemic strokes. Is my screen moving?
No, it's not moving.
Just a second. Sorry. Was concealed allocation used in the allocation of interventions? No. Since this was an open label trial, concealed allocation could not be used. Were the groups treated equally apart from the experimental intervention? Yes. Both the groups received medical care which was similar. And were the groups similar at the start of study? Yes. Here we can see the baseline characteristics of the patients, which were almost similar in endovascular therapy and medical care group. There was no significant difference when it came to age, gender, or race. Was the randomization process clearly described? Yes. Patients were randomly assigned in a 1:1 ratio to undergo endovascular therapy or medical care alone. Randomization was performed with the use of central web-based module with an adaptive procedure to balance groups across preclinical and imaging characteristics. It was a simple randomization process. And was the blinding used effectively? No. The patients or nor the persons who conducted the trial could be blinded, since only the endpoint assessment blinding could be done. Was the trial of sufficient duration? Yes. The trial was stopped early after the second interim analysis because of evidence of efficacy of endovascular therapy right after second analysis. And was the follow-up complete? Yes. 300 patients completed the 90-day follow-up, and score of MRS was assessed at in-person visits or by means of telephonic interviews. The trial had a few limitations, such as it was an open label trial, so chances of bias were more. Early termination could have caused the treatment effect to be overestimated. Also, the sample size was smaller than anticipated and hence underpowered for subgroup analysis. The percent of patients receiving IV thrombolysis was low, which may have disadvantaged the medical management group as compared to the endovascular therapy group. Also, patients with high aspects value and large infarct core volume were uncommon at the trial centers. Hence, no conclusion could be drawn about patients with these characteristics. And patients older than 80 years of age were excluded from the study due to risk of ICH after thrombectomy. The study was conducted with intention to treat analysis. What are the experimental and control event rates? Experimental event rate was 0.52, while control event rate was 0.39. Here we can see that the symptomatic ICH at 90 days was more in experimental event group. And absolute risk reduction is minus 0.13. So there was more risk of adverse events in the treatment group, intervention group. Relative risk reduction is the control event rate minus experimental event rate upon control event rate, that is 0.33. And number needed to treat is minus 13.
No, it is 1300 by 13, no? So
yes,
minus is removed. So you feel it is advantageous to treat or not?
So the number needed to treat is pretty high, but it is still advantageous in the at 90 days if we compare with medical care alone.
So there is some miscalculation here, but 13 is not a very high number. In thrombolytic therapy is also 13 is NNT. See, it's a good number. It is not 100 or 200 NNT. That means out of 13 patients, if you treat one will be benefited, is a good number.
Yes.
but maybe some problem in calculation. We'll have to check it later.
Yes.
Okay.
Going ahead, will the intervention help our patients? Yes, endovascular therapy will definitely benefit the patients because large vessel strokes with large infarction, they cause significant neurodeficit in the patient, and EVT can be done within a longer window period, increasing the chances of survival as well as recovery of the patient as compared to medical therapy alone. And are the benefits worth the risk and cost? Yes, the benefits such as improved quality of life at the end of 90 days from onset and early neurological improvement offset the small increase in risk of any ICH. Also, increased expenses related to endovascular therapy, considering the ICU stay and the procedural cost, may be balanced by improved quality of life and early functional recovery. The patient's values and preferences have been considered in this trial as informed consent was taken from patient or relative before enrollment in the trial. Avenues for future research that include, even though a patient with aspect value of 0 to 2 is considered to be unlikely to benefit from EVT, this trial explored this possibility, but no conclusion can be drawn about this patient group as the trial was not powered for this analysis. And more trials are warranted to determine if this benefit is valid in patients with aspect 0 to 2 as compared with aspect 3 to 5. Concluding, among patients with large ischemic strokes, endovascular thrombectomy resulted in better functional outcome than medical care alone, but it was associated with more vascular complications. And cerebral hemorrhages were infrequent in both groups, but slightly more in EVT group as compared to the medical management.
They gave both altiplase and tenecteplase, isn't it, in this?
Sir, altiplase or tenecteplase either was given, depending on location of the
They
trial.
didn't give a different, how many were given altiplase, how many were given tenecteplase, in which cases the hemorrhage is more?
Sir, that they haven't given in which cases more, sir.
Okay. So, comments, Dr. Vivek?
Yes, sir. Again, the same results, more or less like previous study only.
Maybe I think here there is a contamination. It is a tenecteplase and altiplase. Anything can be used.
Previous study also they use altiplase and urokinase.
Urokinase. So
I don't know how to interpret it.
Both the studies have used different agents, which may affect the end result.
That is true, sir. That is true. For medical management, that is true.
But is it true?
The second thing interesting to see, yeah, they have done a lot of thrombectomies, but vessel-related complications rate is little high. I feel little higher. They have shown some complication, dissection, spasm. Spasm is okay, but perforations were 7. And some dissections were for 14, 15 dissections. So I feel that rate is little higher, and that could have hampered the final outcome also. And only 78% of the patient they were able to achieve successful revascularization. Not all cases. I think this slide one slide above.
About this revascularization.
Revascularization, I think they will able to achieve. No, I think one slide down. I think I have seen. Because you are shown the safety profile, na, that slide.
So this one.
Yeah, you can see dissections happen 10 dissections. Perforations were 7. And spasms, okay, spasm can happen in any of the cases. But 17, and it's almost like 10% complication rate, which is quite high, I feel.
I think maybe there are many centers. This is a
yeah, that is
yes, sir. Conducted in 5 countries.
Yeah,
5 countries. Which countries? European countries or?
So Europe, across Europe, North America, Australia.
And the access site complications are very minuscule.
It's global, I think. Then
sir, but the access site complications usually we see more than the vascular intravascular complications, intracranial vascular complications. But here it's a little reverse.
Because expertise is different in different countries. Maybe
that is true. So that is true. And I think they have mentioned some Japanese trial which has clearly shown that particular group I was talking about, 3 to 5 aspects.
Yes.
Yes, sir.
So that was, I think, the study we can just read about, and probably we'll try to extrapolate that results.
We'll make our own protocol for this.
Yes. Right. Japanese one quotation, I think, study she has quoted.
Yes, sir.
Japan limit trial.
Yeah. So they have selected study aspect 3 to 5.
Yeah. I wanted to ask one thing. There are some studies coming where after mechanical thrombectomy, they are thrombolizing. Have you come across any studies?
Oh, no, sir. No such discussion is going on. So I am not aware it, but I have to
Post,
read again.
post EVT, they are
Ah.
now pre and post thrombolysis.
Okay, I'll read, sir. I'll read. This is new to me
Pre and
also.
post EVT thrombolysis, which I was scanning through in some of the studies.
Okay, okay.
I think Dr. Gargi, very nice. I think thank you very much. We'll go on to last presentation, that is the comments by Dr. Dulari.
Thank you, sir.
Mary, can you?
Yes, sir. 1 minute. Are you able to see my screen?
Yes, yes. You can put it on slideshow.
Is it on slideshow?
Yeah, it is on.
Sure. So I'll just be going through the two trials which Srihari and Gargi have spoken about, and in brief about the Japanese trial, which is the third trial which had similar results. So we've been generally talking about improved prospects of thrombectomy in large ischemic strokes. So mechanical thrombectomy, it is one of the most effective treatments in medicine with to prevent disability in stroke. In one patient with stroke, number needed to treat is 2.3, and this can be performed up to 24 hours after onset of stroke, and recanalization rates are around 70 to 80%. But all these studies have been done because till date mechanical thrombectomy has not been recommended in patients with large strokes. This is because of two main reasons. One is the potential reperfusion injury in necrotic brain tissue, and the second is because of increased risk of hemorrhage, edema, disability, and death. In fact, the large strokes that these trials are addressing represent up to 20% of all acute ischemic strokes. So what are large strokes? All these trials have defined large strokes with a CT aspects of less than equal to 5. Some have also taken from 0 to 2, which is a very low aspects, and an ischemic core volume more than 50 ml. One study took more than 70 to 100 ml. And what have they defined as good outcomes? A modified Rankin scale score of 0 to 3 at 90 days follow-up after the stroke. So I'll speak briefly about the Rescue Japan Limit trial, which was the trial that we didn't touch upon in this. So the patients that they looked into were large anterior circulation strokes with proximal vessel occlusion. The intervention was endovascular thrombectomy compared to the control, which was medical management. And the outcomes they found were mechanical thrombectomy had better functional outcomes than medical management. Symptomatic intracranial hemorrhage was not significantly higher in the mechanical thrombectomy group. All intracranial hemorrhages were higher in the mechanical thrombectomy group when compared to the medical management group. The incidence of edema, hemicraniotomy, and death was not higher in the mechanical thrombectomy group. The major limitations of this trial were it was done exclusively in a Japanese population, so there might be racial differences, might not be generalizable to other populations. And in Japan, they use a lower dose of alteplase compared to other countries. So whether these results could be generalized to other populations where usually a higher dose of alteplase is used. Also, the patient selection in this study was based on MRI rather than CT perfusion studies. I'll also just give one slide on the two trials which have already been discussed. The SELECT-2 trial, this was an international trial across various countries, USA, Canada, Europe, Australia, and New Zealand. Recruitment had to be stopped midway because of the positive studies of the previous Japanese trial which I mentioned. They looked at the primary outcome as modified Rankin scale at 90 days, which favored mechanical thrombectomy. And the secondary outcomes, which were more than double in the mechanical thrombectomy group, were functional independence, that is an MRS of 0 to 2, or independent ambulation, which is an MRS of 0 to 3 at 90 days follow-up. Symptomatic ICH was infrequent and rates were kind of similar in both groups, whereas the incidence of death was also similar in both groups. In the Angel Aspects group, which was in an exclusive Chinese population, good outcomes were seen in 47% in the mechanical thrombectomy group compared to 33.3% in the medical management group. Here also, symptomatic intracranial hemorrhage, all intracranial hemorrhage and hemicraniotomy rates were higher in the mechanical thrombectomy group. So in conclusion, all these three trials seem to show the benefits of mechanical thrombectomy, which are consistent across age. All have included patients from 18 to 80 years, degree of neurological deficits, which are large infarct cause, different imaging characteristics, different time from treatment, but all within 24 hours of the onset of stroke, and across different geographical locations. Mortality was similar in all trials, and a shift to worse this is what I explained with the MRS chart in the first trial. Sometimes a therapy might prevent death but increase the morbidity by shifting a patient from MRS 6, which is death, to an MRS 5. But in all three of these trials, all the MRS in each category was better in the mechanical thrombectomy group compared to the medical management group. So in conclusion, all these trials seem to suggest that mechanical thrombectomy should be offered to patients with large anterior ischemic strokes who make up around 20% of all patients with acute strokes. Thank you.
Good. I think very well summarized, Dr. Dulari. Our main problem, as I can see, is the calculation of volume, stroke volume. What do you say, Dr. Vivek? Dr. Dulari, it's very difficult to calculate volume. We can go by aspects. Vivek, are you there?
So the volume they've calculated, one study used exclusively the rapid software.
Oh, okay.
And the other one, they had, I think there was a mixture of CT perfusion as well as MRI, where they've looked at diffusion flare mismatch. So it's not been uniform, but in one study, it is exclusively rapid software was used.
If we want to design, then we should have a method of doing this volume assessment. Dr.
Yes.
Vivek, you can unmute and talk. You are muted, I think. Anyway, I think we had a good discussion. I think Vivek is not coming online. We'll draw a protocol, Dr. Dulari, and
Yes.
thank Dr. Dulari and Srihari and Gargi. Then we'll close down now. We'll make our protocol for large vessel occlusions and the strokes. And any comments or any questions from anybody before I wind up? If there are no comments or questions, I think I'll say good night to all. Okay? Take care.